So very briefly, welcome to the Patients Redefining the Future of Healthcare in Canada, 9th Annual Summit, pre-summit webinar, Melanin Myths, Black Skin Misconceptions. We have some amazing speakers who Louise will introduce, get us started introducing us to. But very quickly, just a reminder that if you haven't registered for the full summit yet, November 19th to 21st, there's still time, so please do. Next slide, please. So again, welcome to the presentation. Next slide, please. We have 3 great speakers and an amazing moderator who, again, we're diligently working to bring on. And I did want to acknowledge, of course, that we are joining from across Canada. And I am grateful to be joining from the traditional territory of many nations in Toronto, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Métis, and Inuit people. And we also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. And as always, we welcome you to share your own land acknowledgement because we are coming far and wide for this session in the chat. So thanks, Louise, and I turn it back to you.
So I'm introducing an amazing woman, Sharon Davis-Murdoch, CM, and she's a social justice champion, no question. She retired from the Nova Scotia Public Service, and she's taken up political science. She has a political science background and public policy experience, which informs the work that she does. She's worked at the community level and is a founding member in 2000 and the current co-president of the Health Association of African Canadians. And I was very pleased to have the opportunity to meet her. Among her public health accomplishments was the development of the first provincial guidelines for culturally competent primary care in Canada. That's amazing. Congratulations. She's a recent recipient of the Queen Elizabeth II Diamond Jubilee Medal and the King Charles III Coronation Medal. She's been made a Paul Harris Fellow by the Halifax and Dartmouth Rotary and Rotary International, and she's recognized for her commitments. This was given to her, recognize her commitments to service for all. In 2010, she was made the Order of Canada for dedication to culturally competent care and improving the health equity and inclusion of racialized communities in Nova Scotia. Sharon received the Premier's Awards of Excellence in 2007 and again in 2015. Sharon was a key initiator of Dalhousie's Promoting Leadership in Nova Scotia Health program, and later received the Inspiration Award from the Dalhousie School of Public Administration, awarded to public servants who have demonstrated a superior dedication and commitment to mentoring, coaching, and inspiring students and public servants over the course of their careers. Post-retirement from the Nova Scotia government, Sharon was appointed and served as a commissioner on the Independent Commission on Effective Electoral Representation of Acadian and African Nova Scotians. Sharon is a co-manager of the Association of Black Social Workers and the Health Association of African Canadians Black Health and Wellness Initiative. She is an advisor to the Halifax Immigrant Partnership and secretary of the Dartmouth General Hospital Foundation Board. Furthermore, her mentoring and coaching commitment has served through her leadership as a lead co-facilitator of the East Coast Public Policy Institute. President. So Sharon is a proud member of the Dartmouth community and an even prouder nana of 2 growing boys. I don't know how you have any time at all, Sharon, but maybe you can explain how you do that.
Well, thank you so much, Louise. That's a very kind introduction, and I was thinking it was going to be a lot shorter than that, but here you go. I'm really pleased to be here, and good afternoon, and thank you to colleagues from all over Canada for joining us for this webinar, and it is a first focused on Black skin. Thank you so much to the Save Your Skin Foundation, Louise and Sylvia and their team, including, and let me give the full name: Sylvia Larico, Louise Binder, Antonella Scali, Leah Stevenson, Kathy Bernard, Katie Dennis, and our French interpreters, Ciro and Gerard. I am delighted that that they saw fit to introduce us and to invite us to be with you today. I want to say that we're very, very pleased to be here. We appreciate the support and encouragement of the Save Your Skin Foundation and all of you. We are wanting today to address this aspect of healthcare that has kind of been left out of Canadian health system priorities. We are going to be presenting on behalf of our organization. As you heard, I am a founding member of the Health Association of African Canadians, also known as HAWC, not HAC, HAWC. I am Sharon Davis-Murdoch, and I'll be moderating the session. Now, joining me are our HAWC directors. We're all HAWC directors, but we are among us Dr. Yinka Akin-Deko, Mr. Mario Roll, and Director and HAWC Treasurer, Mr. Liston Bailey. Mario has his Master's of Social Work at RSW from St. Mary's University and the Dalhousie School of Social Work. He was Health Service Manager for Nova Scotia Brotherhood and currently is working with the Office of Workplace Mental Health. Liston Bailey has his degree, University of Technology, from the University of Technology. He is our treasurer at HAWC and currently a small business relationship manager with over a decade of experience in the financial services industry. As you know, as you have seen, I'm sure, from the promotions, Dr. Yinka Akin-Deko, many letters behind her name. I won't read them all, but she is a family physician right here in Dartmouth, where I live. And she has a special interest in dermatology and health equity. She is a member of HAWC and an advocate, continuing advocate for health equity. So my colleagues and I come to you with diverse backgrounds. We represent clinicians, health policy leaders, and finance professionals, as I've mentioned. We are also African Canadians with lived experience, committed to our communities and the improvement of Black health outcomes. And I would like to just give you a little bit of background of HAWC. HAWC was formed in 2000 to address African Canadian health issues and the system inequities affecting health. Throughout these many years, we have developed valuable connections with African Nova Scotian and Black community members across our province. We are excited to connect community members and project partners to ensure that lived experience is at the forefront of this work, and you'll see that as we unpack today's webinar. HAWC's vision is to create thriving, healthy African Canadian communities in Nova Scotia, and our mission is to promote and improve the health of African Canadians in Nova Scotia and beyond through community engagement, education, policy recommendations, partnerships, and research participation, all within a cultural competence framework. This is very important to us. HAWC identifies people of African ancestry among those facing disproportionate health disparities and inequities in all aspects of Canadian life. Consistent with the literature on the social and structural determinants of health, people of African ancestry face systemic, anti-Black racism, disproportionate risks for certain diseases and disorders. We suffer from higher rates of chronic disease and have reduced life expectancy. With that, we unfortunately access care less frequently and face inequities in the quality of care that we receive. So with that in mind, today we will begin the session with a presentation from Dr. Yinka, who is passionate about Black health and Black skin matters. And she is continuing to develop groundbreaking expertise in this neglected area of care. Following Dr. Yinka's presentation, Mr. Roll and Mr. Bailey will use probing questions to unpack the dimensions of care needs, health system responses, and the need for system change. And in the last half hour or so that we have together, we will invite you to add your questions and your voice to the discussion. So with that said, I hope you are ready, Dr. Yinka, because I'm going to pass it on to you. Thank you.
Thank you so much, Sharon. This is so exciting. Thank you, Save Your Skin Foundation. This is my passion. So this is like you could wake me up in the middle of the night and I would give you a 1-hour talk on this. So I live, dream this. So I'm just so excited to get into this topic. And I'd like to thank Sharon because you've just talked about half of what I want to talk about already, about the cultural competence, the trust and access and equity in care for our population. I'd like to share my screen if that's okay. I hope I have access. Yep, okay. So give me a second. There we go. So today we're talking about melanin myths, and that's a topic that I have chosen because it's a topic I've thought about in so many ways, not only from the skincare perspective, but also from our thoughts about what Blackness represents. So way beyond what the skin looks like, things like Black people feel less pain, or Black people are more likely to do this or that. So it's a topic that it's kind of broader than I'm presenting it today. But for today, we will concentrate on the skin part of it because of the forum we're on and the aims and goals of the foundation. So what will we be talking about? We'll talk about prevalent misconceptions about Black skin, from sunscreen and to systemic barriers in healthcare. And I did look up Save Your Skin, and I see that you're an advocate for the use of sunscreen in Black people, and that excited me to no end. So I thank you for not ignoring it. And we'd like to talk about some common myths. I'd like to provide some facts. And even with the facts that I'm providing, I'd like you to remember that Africa and descendants of African ancestry have the highest levels of genetic, so genes, phenotypic, the way we look, variation amongst all humans. Africa has the widest and the highest levels of variation. Because if you think about it, the shortest humans are Africans, the pygmies, right? The tallest humans are Africans from South Sudan. You can get the lightest of the lights from the North Africans. You can get albinos, and you can get the dark, deep melaninated Africans that you see in South Sudan. The fastest man till today, Usain Bolt, is of African descent. And the marathon runners from Kenya are Africans. So such a wide range of genes that it's almost impossible to say, this is the fact, run away with it and treat all the same way. Just impossible. Always have that at the back of your mind. So I've just kind of grabbed this online, offline to show you how much variation, where you can see this light skin, albino, and the deep dark skin of the South Sudanese, like I said, and Somalians. So, so the first myth that I want to talk about, which links into what Save Your Skin's already talking about, is that Black skin doesn't need sunscreen. Such a common misconception, because even Black people believe this. By far the commonest question I would get asked is about sunscreen for Black people. And the thinking is that melanin protects us from the sun. Well, it does. Once again, thinking about the variation. If you have very little melanin because you're extremely light skinned, then you get no protection, which is why albinos in Africa have really high skin cancer rates, almost the same, if not more, than you would see in the West or in places like Australia with really high melanoma rates. Melanin offers an SPF value of between 4 to 13. Most dermatology colleges and dermatologists would advise at least an SPF of 30. Melanin will protect you from a UVB, ultraviolet B rays. Dermatologists would advise you to have a broad spectrum protection, so you don't get full protection with melanin. Many people feel that Black skin will not burn in the sun. Even many Black people feel they don't burn in the sun. Then I always ask them, when you go on holiday, do you not know the difference? Don't you tan deeply? And that's one of my gripe with the Fitzpatrick system of classifying skin, where they say less likely to burn, more likely to tan. Because your Black skin, you do not, it's harder to see when it tans, then doesn't mean it doesn't tan. Many Black people will tell you, I can tell the difference when I've been in the sun. If that's not tanning or even sunburning, then what is it? I will show you a picture of sunburn in a minute. And if sunscreen is a common question, then probably the second commonest is post-inflammatory hyperpigmentation, where we know that Black skin tends to heal by forming dark patches. And post-inflammatory hyperpigmentation is made worse and aggravated by the sun. So if you have a skin injury and you're able to use sunscreen and protect yourself from the sun, it reduces the chances of you having post-inflammatory hyperpigmentation. Then the question becomes, what sunscreen? And I'll tell you a story that happened to me many years ago, part of why I'm where I am. I was once invited to a skincare, testing training. And this company is literally the top cosmeceutical. So it was formed by a dermatologist in the US, very popular product, quite expensive, luxury, top range, science-based. And they would train you how to use the product, how to do chemical peels, and talk through the product, what it had in it. So there were about 4 of us, all doctors. I, the only Black one, had this training, was told about this training, and we could all go through the training together. So the first person went, the second person went, and then it was my turn. And then they applied this, and that was it. And I stood up. And the guy on my left, the doctor on my left, bumped me and said, I think you need to wipe your face. And I took a paper towel then and wiped my face. I thought there was a bit of product left on my face. And then a few seconds later, you could see he wasn't comfortable. So he bumped me again. You need to wipe your face, maybe use the wet wipe. So I got a wet wipe, and I wiped my face. And a few minutes later, he said, I think you need to go to the washroom and wipe your face properly. I'm like, okay, thank you. So I go to the washroom, and it's one of those kind of fancy washrooms. Immediately I went in, there was a huge mirror with lights and all of that. And I looked like I had stepped off the set of Avatar, the movie. It was bluish white. I looked terrible. And in that minute, with the lights looking at me, I'm like, what was that? You just rethink the whole situation. First of all, why do you make a product that's not for me and invite me into this space? Then even more so, why don't you make a product that works for me? If you're making a good product and you're a scientist, why are you not thinking about me? And for this reason, many Black people will not use sunscreen because they look really, horrible with a white cast or blue tinge that would not blend into the skin. So if I don't find one that looks good on my skin and I don't even know that I need it, why would I use one? So I did a thing with AI. Everyone's gone AI now. And I asked AI to get me an image of what sunburn looks like on Black skin. And it drew up, put up this image on the left, with the man that you can see the hair, a man or woman, I'm not sure. And it gives this image of a redness and, looks really bad. There's something wrong with the skin. But for many Black people, it looks more like the image on the right, where this is this person's arm and it looks dry and scaly, and people might interpret that as a dryness and say apply moisturizer, rather than you've been sunburned, don't do this again, make sure you protect your skin. So that's a good representation of how even sometimes in the post-burn phase, we miss the teaching for our patient. So the second myth is that skin cancer is not a concern for Black people. Of course it is. Where melanoma is not that common, because like I said, melanin offers a bit of protection, except in the extremely light-skinned people, and melanoma still occurs. And by far for Black people, as against white people, squamous cell carcinoma is the commonest type of cancer Black people will have. And with melanoma, we're more likely to present late. So although Black people do not have as much melanoma, when they do have, is more fatal. I'm going to talk a bit more about melanin loss. In where it could be acquired, is the person that's kind of brought it on themselves, or even things like vitiligo, where it's, is an autoimmune disease, you have kind of no control over it, which is what Michael Jackson said he had. And so in those situations, do we kind of rethink and say, okay, still a Black person, but doesn't have as much melanin to protect themselves? So next slide, I just wanted to point out on the right here, the discrepancy in the death rates for melanomas in Black versus white people. And on the left of my screen, we've got my favorite musician of all time, Bob Marley, the One Love. Listen, when I practiced this song yesterday, it sounded much better in my living room. And my son was like, oh, sing it more for them, Mom. But I'm a bit crackly today, but still the One Love guy, and who died from a kind of melanoma at a young age. We still have his music to enjoy, but he died from a kind of melanoma called acrolentigenous melanoma. And this is usually the kind of melanoma you would see in Black people. So it would be on the palms of the hand, on the soles of the feet, or in the nail bed. So if you were even a doctor or a healthcare provider looking at a Black patient, you would have to go out of your way to look at these areas. These are not the areas that you think of first. And also the patient, you would have to go out of your way to examine these parts of you. I think we believe Bob Marley started in his nail bed, and he refused treatment. So once again, just plays into the trust and access for a man that probably had the money, probably had the people that could treat him. I don't know what was going through his mind. Maybe it was, I don't know, I can't say. So another misconception I want to talk about is education. And I would like us to think about education from almost 2-3 parts. So from the healthcare provider point of view, from the patient's point of view, from public health point of view. I trained in Africa, I trained in Nigeria, and I can tell you that despite me training in Nigeria, our textbooks were very Western focused. Our terminologies were very Western focused. So for example, they would describe things as looks like grapes, right? We didn't have grapes in our surrounding, but we had other fruits that looked like grapes. And so then there's a disconnect when you're reading the book. You're like, ooh, grapes or walnuts, shaped fruit, like what's that? There were things that we could use around us, but then it wasn't used in the books. The same with the patients, where imagine a first generation migrant, a doctor's describing something to them and says, is the shape of something, is the shape of pomegranate. What's that? I don't know, so they don't know what to look out for. They don't know what to present to the doctor with. And then the images we see ourselves. When we see sunscreen adverts, does it concern us? Do we see ourselves in those adverts? If I see an advert about children and I'm not a child and I don't have children, then I ignore it. It doesn't even register in my brain. So the same way, so our public health images, our public health campaigns, advertisements for skincare products, are they representative? Do I see myself in those images? So I'll give you an example of a picture that we see in our medical textbooks. So this is a condition called psoriasis, which is an autoimmune condition. So the body kind of attacking itself. And on the right there is a typical textbook image of what they would describe to us as what psoriasis looks like. But that's more common in lighter skin. And on the left here, with the kind of more whitish, less of the red, is what you would see in black skin. And I remember I had a cousin, I have a cousin, he's still my cousin, had this as a child. And people around would say, oh, you just need to scrub a bit more. You need to clean it a bit more. No one had the understanding that this was a condition that needed to go to the doctor, needed to be treated. So he lived with it all his life until he was an adult and it was able to kind of like, look, I've scrubbed it for years. It's still not working. Then when our patients come to us, are we aware, are we culturally competent to realize that maybe not all skins are created equal? I'll tell you a story about an encounter I had once. It wasn't my encounter, but I was involved in it. I am part of a Facebook group made up of doctors who talk about skin, mostly dermatology. So if there are cases that they don't know what it is, so they'll bring it up with the patient's consent. They would have said, I'm going to discuss this with other doctors. Is that okay? Patient says, okay. So they bring it on this group. They bring a picture. We look at the picture. They tell us a bit of story and we try to diagnose it. And on this particular day, I got into this group and there was a Black woman who had some dark patches on her cheeks. And this doctor said, I don't know what this is. I've been trying to treat it with a particular laser and it's not working. There were so many levels to this discussion by the time I logged on. It had been going on for a while. And people were like, oh, it's this thing, is this, that, is that. And then someone said, I think you should pull back. She had a wig on because many Black women wear wigs. It's part of dressing the way you would have a lipstick. Many Black women wear wigs. And someone said, tell her to take her wig off because there might be something in her scalp. Now, this is a culturally competent issue, I tell you, because for that woman to put that wig on, it might have taken her hours and it might have cost her a lot of money because she had to lay it on so perfectly so it looked so real, or it looked good to her. It didn't have to look good to anyone else. So when you tell her to take her wig off, there are so many layers of indignity, especially when she did not need to take that wig off. For me, looking at it, it was an easy diagnosis. I said, oh my goodness, this is exogenous ochronosis. It's because this woman had used maybe steroids and hydroquinone for many years to lighten her skin. And she's developed this irreversible damage to her skin. And all you needed to do was kind of talk to her and try about the skin lightening issues and try to teach her how to heal her skin so she could wean herself off this product. Lasers would not help. And many times, many of the lasers we use are not made for the Black skin. So in one picture and one encounter, it just showed how much we were failing our Black patients. I said to you that at the time I'd logged in, the discussion been going on for so long, and no one had been able to diagnose and say this is what it was. But I thought to myself, if you asked a random woman off the street of Lagos, what's wrong with this patient? She will tell you because she's seen it all around her, right? So that's another thing that I want us to have in the back of our mind, especially with the issue of neocolonization. So I'm trying to make everybody a little bit uncomfortable in the room now, because when the colonial masters came, and then when we watch Western TV, and then when we consume Western media, we know the standard of beauty. And the standard of beauty is very European. It's very straight hair, it's very light skin, his nose a particular way, his lips a particular way. We've all imbibed it. Even I in Canada, many of my patients will complain, oh, my hair's too curly. I'm like, it's absolutely stunning. What's that? Or, oh, my nose is too, we have all these things that are wrong with us because our standards of beauty have been dictated to us. So we have this hair relaxing and hair perming culture where we straighten our natural Afro hair. And many of these relaxers, if not all of them, are skin irritants. So it will break the skin when you go to apply your relaxer, because you're applying onto the new growth at the root of the hair. So many times the skin's broken, and when the skin's broken, these chemicals are more likely to penetrate and you absorb them into your bloodstream. And there are lots of studies out there ongoing, and some suggesting that this increases the risk of things like endometrial cancer, and which is why we see more things like fibroid and maybe even the breast cancers in Black women. And I think there's a court case going on in the US at the moment that someone's suing some company about this. So when we see that, do we kind of use that opportunity as a teaching, or recognize what's behind it and how we break it down to our patients? And then access. We talked about Bob Marley, and we talked about systemic racism, how many doctors are in the Black community, and the doctors in the Black community, are they happy to be there? Grateful for public health in Canada. There are places in the US where you just have to have money. And if you're the least earning in the society, then how do you pay for good health care? And then do the patients trust us, the healthcare providers? Do they know that we will do our best for them, that we would care for them? In many ways, I say the Facebook story and to highlight a point, but I was so proud, and I'm still so proud of the doctor that brought that case on, because she's like, okay, I don't know this, and I want to know. Do we healthcare providers want to know? Do we want to improve our knowledge so that our patients can trust us and see us as advocates for them? I don't know everything. I really don't know. I don't even know a lot. But am I able to kind of push through and say, okay, let me ask someone else that knows, and do that with empathy and kindness, and say, look, this is new for me, but let me ask, and I'll get back to you on that. So I talked about our textbooks not being representative. So a couple of advances recently on this. I think there was a guy in Nigeria, there was a medical student in Nigeria who published illustrations in obstetrics where there were Black babies, and there was a lot of pushback, but there was a lot of gratitude as well. That for me as a doctor, all my life, my obstetric textbooks, all the babies looked white. There were no Black babies, but there are Black babies being born, right? So that was good. There's another doctor who's also published some dermatology, skin diseases with representation from Black skin, and lots of our website, like the Dermnet I showed, is also kind of updating and being more diverse, because that's how we get improved patient outcome. That's how we get the patients to trust us. So we need more data, We need more audits. We need more research, representative of the people on the planet. So my last slide, okay, I try not to take too much time because I'm hoping we can kind of have more of a chat after this. Sunscreen, everyone needs sunscreen, and we need ads that show that we need sunscreen, that everyone needs sunscreen. We need public health campaigns to include all skin types. We need support for entrepreneurs, funding, loans, you know. Black entrepreneurs are less likely to get funding, are less likely to get support. So if people are making skincare that protects Black skin, then we need to be supporting them. We need education for everyone, government, patient, healthcare provider, and we need to be advocates at all levels. And that's what I'm hoping that everyone in the room today can just go out there and be advocates and realize that there's more to learn and more to do. And that's done. Thank you.
My goodness, Dr. Yinka, that was so powerful, and so we so appreciated it on a couple of levels. I want to first acknowledge your trauma, the trauma that you endured in your career, and you know, and what no doubt fueled your passion in this area. What you described was pretty horrific, what happened to you as a physician with other physicians being treated like that with so-called upscale products and made to endure that. And when you speak and when you've spoken about many other things, you have talked about our trauma and shone a light on the things that we as Black people go through in terms of our skin and care. I really want to now open the opportunity for Mr. Mario Roll, and then Mr. Liston Bailey to ask questions. And brothers, if you want to introduce yourself a little bit more than I did, I certainly invite you to do that. I did not give you probably the kudos that you well deserve. So speak your truth and who you are, and then ask Dr. Yinka your questions.
Sharon, you did an amazing job. But let me do this here. My name is Mario Roll. I work with workplace mental health for the province. I also run my private practice. I work with tons of clients of color. But there was something, Dr. Yinka, you touched on, and it's around access. And there's different types of questions around access, but this particular one that I have in mind is more so around the barriers we face, visible minority people face when it comes to accessing a dermatologist. How can we as clinicians help address these challenges?
So recently I was in Chicago for a conference, and one of the things I learned is that the US has a family physician training for a training geared to family physicians to learn dermatology. And I thought, oh my goodness, this is amazing, because there are many family physicians, me including, that would love to do that. Then it becomes, are you going to go to Texas for a year? I can't leave my patients. Some of them waited 8 years to get a family physician. Mario, some of my patients were waiting 8 years to get a family physician. What are they going to do if I took time out of practice? So everyone now needs to be trained. If you're a healthcare provider, you need to be trained how to recognize skin conditions in Black people. Yet we do not have enough dermatologists. The dermatologists we have to be culturally competent. They have to be open and accepting of the diverse skin types that we have in the country and how to manage them. And I'm hoping that our skin of color patients will know that we are here and want to look after them, that they can trust us and come to us with their complaints.
Thank you so much. I'm going to take turns with Mr. Liston and then back to you, Brother Mario. So Liston, Mr. Bailey, perhaps you could introduce yourself and share a question with Dr. Yinka too.
Thank you very much, Sharon. My name is Liston Bailey. As Sharon shared earlier on, over 10 years within the financial sector. And Dr. Yinka, you spoke briefly on, injection and so forth for Black businesses. It's something that I am passionate about, and in my area, we're looking to foster that. Being I'll say a new dad, here in Canada, one of the things that I suffered with or from is that when my daughter was around 3 months, we saw some pimples or some bumps on her face. We went to, our family doctor, we went to the IWK, and we brought this to the doctor's attention, and they keep saying to us, oh, it's just regular baby pimple. It's just regular baby pimple, until she was around 4 months. Then those pimples started to ooze, and she started to scratch them, and then at that point they were like, oh, this is eczema, and they treated her with let me tell you, steroids, right? I was a little bit taken aback at the fact that at such a young age she was treated with steroids. So my question for you, what are some of the predisposing factor that contributes to eczema in kids, and is there any method or means of identifying this early within Black kids?
Thank you so much, Liston. I'm really sorry to hear about your daughter, and I hope she's healing well now. So it's not rare in my practice to find lots of babies, especially Black babies with eczema. It seems like it's commoner in Black babies. And I always joke to the moms that this baby is meant to be on the beach somewhere in Jamaica or Barbados enjoying life. But now there they are in Canada, dry, cold. So I always say to them, in the tummy, it's wet all the time. The natural weather for this Black skin baby is a humid weather where there's lots of moisture in the air. For everyone, people will tell you, when I go on holiday, my skin feels better. So we need moisture. There is no too much moisture. So the baby checks when it starts. So I'm like, okay, let's be on it. Do not, clean just with plain water, and moisture. Every time you're feeding the baby, every time you're changing the nappy, moisturize this baby's skin. Now, eczema in itself is a huge topic, right? It could be due to allergies, for example. And with allergies, moisturizing the skin will not make any difference because it's internal, not external factors. So when we are seeing that it's getting worse, this moisture is it's not doing it, or there are other symptoms, the skin starting to break, this baby is not settling, then we need to get them to see a pediatrician, which is what the IWK hospital is a children's hospital. So they need to see a pediatrician, they need to get diagnosed properly, they need to get treatment. Steroids are one of the medications we use for eczema, especially knowing that it can become quite inflamed. When it's inflamed, it itches more. When you scratch more, you get more breakouts. So steroids will help the inflammation, take away some of the itching, allow the skin to heal, so you can kind of, keep going with the moisturizing.
Thank you, Dr. Yinka. And I'm going to put it back to Brother Mario, because I know he has a couple of follow-up questions. We'll go Mario, and then we'll go back to Brother Liston. Mario, to you.
Thank you. This one, I want you to take your time with this one. This is a 2-in-1 question as it relates to, scarring and healing. I work with a lot of guys that, use a lot of chemicals in their hair. I see a lot have like bumps and scars in the back of their head. Can you explain how scarring may differ in Black skin, and what can be done to potentially minimize this?
Okay. So this is a huge question on its own, right? So there's scarring, then there's a thing at the back of the head. So those bumps at the back of the head is called pseudofolliculitis barbae, which is just a big word for bumps in hair, you know. And Black men also have it along their beard as well. And it's very linked to the way the Black hair grows. So Black hair is very curly. And if you use the wrong shavers, then it can kind of, you cut it off in a funny way and then it curls back on itself. It stays in the hair follicle. It becomes a cyst. So it becomes swollen, inflamed, and, you know, and just then scars. Black skin, we believe, although there's some research saying maybe not only Black skin can affect all, but in my experience, more so Black skin, likely to scar in three ways. One, the post-inflammatory hyperpigmentation I spoke about, which is the dark patches, hypertrophic scars, which is when the scars raised, you know, it just like a bump, like it's not rare. You see that in like women with cesarean section or even insect bites, you know, a raised one, or keloid scars. Keloid scars keep growing, and they become like a tumor, essentially. They're not dangerous in that they don't kill, but they look quite unsightly. I had a classmate in secondary school that had keloid scars from ear piercing. And they would take it out and it would grow again, and they would take it out and it would grow again. And that was her whole life through secondary school. Imagine that at that age. There are treatments available, right, to treat keloid scars. Dermatologists are very well versed at managing it, taking it out, injecting steroids, pressure, all kinds of things that they can do to treat it. To prevent it, first of all, don't hurt yourself. Try not to hurt yourself, right? Because it's injuries that trigger it. For men, for Black men, there are specific shavers. And I say the best expert for that is the Black barbers. They know, because when men go to, it never really happens. It's when you tend to shave at home that it happens. So it's try not to cause the trauma, use the right shavers. If it happens, get it treated. Mm-hmm.
Okay, thank you. Brother Liston?
Dr. Yinka, you spoke earlier on about the melanin, right? So my question to you, is tanning a safe way of increasing melanin?
So we always want the thing we don't want. We always want the thing we don't have, right? So when you're light skin, you want to tan. When you're dark skin, you want to lighten your skin. Be happy with what you've got. There is no safe way to change. Look after the skin you've got, you know, use your sunscreen, stay in the shade. I mean, that you can tan with the creams that you rub on, but tanning beds are no good. And I know that Save Your Skin has done some work with tanning beds as well. They're no good, especially the age that people use them. You know, young people are kind of more body conscious, so likely to start using, and you know, the damage just accumulates. So apart from using the rub-ons, the creams and lotions to tan, I wouldn't recommend any other way to tan. Definitely not sitting in the sun, and not tanning beds or tanning salons.
So Black is beautiful no matter what your Black skin is.
Yes.
I hear that.
Skins are beautiful. Yes.
That's right. That's right. Brother Mario, back to you.
As it relates to like our cultural consideration, how do cultural practices or beliefs influence the skincare routines among Black skin, and how can we incorporate that understanding into treatment?
So, for example, there's a ongoing debate on social media recently about washing your skin. I don't know if you've seen that, where some celebrities like, oh, I don't wash my baby's skin, and some are like, oh, how dare you? You must wash every day. And for me, that is a kind of almost specific cultural practice, because if you think about it, if you live in Africa, like I said, or in the Caribbean, it's very humid. When you go out, you come home, you're sweating, you feel you need to wash to feel comfortable. So it's not rare that many Africans and people in the Caribbean will wash twice a day. And when they migrate, they do the same and teach their children to do the same. So it becomes a cultural practice anywhere in the world you find someone with African ancestry. And then someone with a European ancestry, where it's cold many times or most times in the year, access to water might be difficult. I once heard that the term don't throw the baby out with the bathwater. I don't know how true it is. It's because people would have used the same bathwater so often that it becomes so murky that if there's a baby in there, you don't know, and you just throw the baby out with the bathwater, literally. So this is the background of our cultural differences. If we know that that's where we're coming from, then it helps us to understand where you don't say you're washing, which is something I've heard literally. I have heard this literally. Black people wash so often because they're dirty, because their skin's dirty. Or Black people saying, white people are so dirty, they don't wash. These are cultural preferences that have been passed down from our ancestors, right? Sewn into our genes. Are there better preferences? Maybe. For me, I feel like when you wash, especially when you have like a flannel or washcloth or the exfoliating gloves, it helps to get rid of dead cells. It helps your skin to kind of rejuvenate itself. Maybe that's part of the reason why Black don't crack. I don't know. That's a theory. But but so there is benefit, and there's probably a reason behind why we do what we do. It's just to be respectful to each other, essentially.
Right. I'm just going to ask if Brother Mario had a follow-up with respect to cleanliness, just in case he had a two-part one there. Was there anything Mario wanted to add to that, or? Okay. I'll move on to Brother Liston then. Have you a third question now, Brother Liston?
Sure. I guess I just like taking on new challenges. As a young man, you always want to ensure that you have a son. Now getting my son, I am here worried and thinking that, am I doing the right thing as a father, caring for an uncircumcised child? From your perspective, can you share some do's and don'ts when caring for uncircumcised child?
Okay. So I have two boys. I had the first one, who's now 18. When I had the second one, there must have been something happened in the hospital, because they came to teach me how to clean the baby. So policies must have changed, because they didn't teach me with the first one. And I remember this health visitor, we used to call them in the UK, they were called health visitors, coming in to teach me. And she said, oh, let me show you how to clean your baby. And I looked surprised. And she said, is this your second baby? I said, yes. She said, was the first one a boy? I said, yes. She said, oh, you don't need it. Is it that when it's your first, or if the first one's a girl? Because people that have boys are like, what's these extra bits flopping around? What do I do with this? And what I say is, wipe what you can see, wipe the bottom. It's fantastic. We've got lovely baby wipes. If you want to use that, you can use like a small towel or flannel, like I say, with plain water to wipe their bottom. Do not pull their foreskin back. Do not pull their foreskin back, because for many of them at that age, it can't be pulled back. If you can see the dirty bits in there, just clean that, leave it, and that should be okay. If you're worried about the foreskin or worried about how the area looks, go see your doctor, right? They will have experience in dealing with that. A barrier cream like pseudo-cream, Baza, zinc, all kinds can be used, but just clean with plain water, a wipe, things you can see, and if you're worried, just get someone else to have a look as well, a healthcare provider.
Very good information to have for parents, mothers and fathers. Mario, have you an additional question?
I get several questions, but I
Oh,
don't want to be greedy. But let me try something here. Doc, this is something we should start with. It's more around the concerns, like, what are the most common skin issues you see in your clients, and how and how do they differ from those in individuals from a different type, like a white person skin.
Okay. So like Liston said at the beginning, eczema is so common with Black babies. It is common. I mean, I don't know how to couch it in the politically correct. It is just, I just find it's commoner in Black babies, and we've talked about that. But the other thing I wanted to talk about is acne in our teenagers as well. Acne seems to occur at the same rate in all races. But once again, like we said about the hyperpigmentation, so the dark spots when Black skin heals, the keloid scars, people form scars, keloid scars from acne, or the hypertrophic scars where it's raised. We need to be treating it early. So we need to be encouraging our young ones to come in, get this treated so that you don't have scars, because scars are harder to treat. Scars are harder to treat. And also, one that's just popped into my head is something called rosacea, acne rosacea, where historically they would say this is commoner in light, fair skin, of Scottish, Irish ancestry. But the truth is, because that's the skin that's easy to see, that's where you can see it. Because with rosacea, you get like the reddish pigmentation. But for a Black person, it looks grayish. So it's not easy to diagnose. It's not as easy for the person to notice there's something wrong, and for the person looking at the healthcare provider to notice. So all of these conditions, we talked about psoriasis, where my cousin had it, melanomas, squamous cell carcinomas, basal cell carcinomas. Black people have skin conditions, right? It's just us encouraging them to come in so we can diagnose it and treat it, right?
okay, thank you very much. And I have a final question for the panelists, and then we're going to hear from many of the participants. There's lots of activity in the chat. So I think the last question was posed by Brother Mario, and now Brother Liston, have you a final question for Dr. Yinka before we open it up to others?
Coming from, and it could be a myth, and I need some clarification here from you, Dr. Yinka. Living in the Caribbean, I was always told that, hey, you don't need to get vitamin D. You get all of that from the sun. So now living in Canada, where we only see the sun for a limited time of the year, what would you recommend to an immigrant myself who may have been misled about vitamin D and ensuring that I get the right amount of vitamin D for my protection and everything?
Okay. When I lived in the UK, I used to do a lot of health checks for people that lived in Nigeria and were just coming into the UK to kind of do like health tourism, health migrants kind of thing. So they would do their health checks, do whatever they needed, and they would go back to Nigeria. I would routinely, as part of my screen, do a vitamin D check. I never met one Nigeria with a high or normal vitamin D level. Everyone had low vitamin D. And this is because you live in your house, you wake up at whatever time, you go in your car, you drive to work in your air-conditioned car, you stay inside the building for 8, 9, 10 hours or whatever number, and then you get in your car and you go back home. Just take your vitamin D supplement. It's really hard in the age we live in to get the amount of sun you need to get vitamin D. And especially so if you're a hijabi woman, you cover up a lot, so you have very few minimal exposure skin surface to get vitamin D. My advice is just safer. That way you're getting enough to get vitamin D supplement. Some people say get it only in the winter months. It depends on where you live. Like if you live in the UK, you barely see the sun throughout the year, right? So just taking vitamin D, 1,000 to 2,000 units every day for the rest of the year. But if you're kind of light skin, you get your walks once in a while, then maybe through the winter months. So my advice is generally for all Black people, 1,000 to 2,000 units of vitamin D every day for the rest of the year. It just makes it a routine and easy to remember.
Fantastic. Thank you, Dr. Yinka. Now, Sylvia, I think you are going to help me with the chat. There are, I know, lots of questions and comments, so we'd like to welcome those. And Dr. Yinka is kindly available to answer what she can. And the rest of us, if you have questions for us, we'll do our best as well. But Dr. Yinka is the expert here. So Sylvia, with your help.
Yep, sure. So the first, I'll just read from the chat here. If anyone prefers to raise their hands and read out their question, they can do this as well. The first question comes from Rhonda Atwell. I am interested in knowing about non-toxic moisturization options, as what is often available to use in Canadian pharmacies and stores is full of chemicals, endocrine disruptors, etc. Are there natural non-toxic options you can recommend for eczema, Dr. Yinka?
So now, eczema and response to moisturizer is very human specific. We're so distinct as humans that parents would tell you, I remember there was a time E45 was a cream was like the best thing. And many parents would say, oh, that made my baby's skin worse, or it made my skin worse. It didn't work for me. You can kind of gauge and see what works. So for example, something like shea butter would work for many people. That's kind of natural as best as it can be. Olive oil would work for many people. There was a time we used to recommend sunflower oil a lot for babies. I actually moisturize. Now I'm not recommending it because some babies, it just clogs them up and they break out, but you kind of need to work out what works for you. So shea butter, olive oil, sunflower oil. Some people will whip up their shea butter as well to where it almost feels like a lotion, so it's not as heavy on the skin. So those are kind of natural alternatives that you can use if you don't want to, if you're worried about store-bought products.
Okay, over to you, Sylvia, again.
Yep. We have from Leah Stevenson. Thank you again for this amazing session. How can patients, caregivers, engaged citizens, and groups that represent them support the needed changes, including through advocacy? What concrete roles can we play?
Which is why, I mean, this is my heart for this talk, where either if you can make changes, you can make policies, you know, if you make adverts, put Black people in your adverts. If you make products, think about Black people when you're making your products. But even if you don't, you're still powerful enough to, when you're going out in the community, if you have a Black friend, you're like, do you use sunscreen? Dr. Yinka says we need, I went for this. I mean, look it up. I tell you, look it up. You do need sunscreen. Or, you know, things like that, where every one of us becomes an advocate. So, for example, I look after a nursing home, and I was on my nursing home round today, and I saw a patient who scratches his skin, and I said, his skin is so dry, you need to do better with moisturizing. Then I stood in the middle of the hallway and said, if I end up here and you do not moisturize me every day, I will be so upset. I'll be screaming, help me the whole day. And you know, that's true. It's all my life I've moisturized every day. Imagine me ending up in a nursing home and someone not thinking about my cultural background and how uncomfortable my skin would be, how much I would scratch and my skin will break, and I would have recurrent infections, because this is all I've done in my life. So no matter where we are advocates for the people around us, just for the knowledge we know now, you know, just for this, we've become advocates. Anywhere you are, if you can organize a talk, if you can make a product, if you can change policy, we're all powerful.
Right. Thank you very much. That question of our relatives and, and mothers and parents in long-term care, or being cared for by others and not having their proper skincare resonates so strongly, I know, to so many of us. Okay, let's move on and make sure we can get as many questions in. Sylvia, there's others.
Yep, from Leanne Walling. We are hearing a lot about alopecia in the media. You spoke about hair relaxers and the chemicals that damage the scalp. Is there any correlation between people, more so women, diagnosed with alopecia and a history of using chemical relaxers?
So in my experience, where what they say, anecdote is not data, yes, and more so with Black people as well. So it's not rare that you see an African woman in her 40s and 50s and she has traction alopecia from years of just pulling back her hair. That in itself is a teaching thing, because she wants to look good, she has to do this, she has to do that to her hair. And then the chemicals, like listen, anyone that's relaxed their hair has had hair come off their head, because this thing burns and you like literally peel off your skin from your scalp when you relax your hair. Like, I don't know if it's possible that it never happened ever to you. So you get lots of hair damage from, putting these chemicals and the hair styling, those tight ponytails. There is a link. Now, are there enough studies? No, there are not enough studies, because we're not really fully being included in the studies, and we're not doing enough studies on just our population. So we need that. So that's another thing that you can advocate for if you're a researcher looking into things like that. We need that.
Thank you, Dr. Yinka. Okay, next question.
From Veronica Marsman. What impact does radiation have on Black skin? I recently had radiation and now I have the marking for the treatment. Should I be concerned?
So that's a very specific question and it's difficult to say, but I wonder if there's a bit of post-inflammatory hyperpigmentation going on there. But that's a very difficult question specifically to answer without knowing the kind of radiation, what you had treatment for, and if that was, how much radiation you have, because many people have radiation and you can see on the skin, and it's just a side effect of the radiation.
So should she follow up then with her physician on that?
Yes, definitely follow up with a physician. Someone would have delivered the radiation. If you're able to follow up with that, that would be really good. Do not ignore it. Speak to someone about it, because it's on your mind. So even if they say, sorry, nothing to worry about, just a side effect, because we can have side effects with medication, but I don't want it to stay on your mind without dealing with it. So please speak to someone about it. I'm sorry you had to go through that.
Yes, agreed. Okay, some one or two more.
From Warren Kelsey. Can you recommend natural skin moisturizers that don't contain chemicals? My dermatologist suggested Eucerin cream or CeraVe. And they also ask if, Dr. Yinka, you would be willing to share your PowerPoint with the audience members for their own resources.
I'm happy to share my PowerPoint, and a CeraVe, Cetaphil, Aveeno, I said about E45, that lots of these products are good. I am not anti-chemical. I'm a doctor. I prescribe chemicals every day. It's hard for me to say, oh, and isn't water a chemical, salt a chemical? Like, our life is chemicals. So sometimes it becomes difficult to kind of separate and say, look, chemicals are not bad. Everything can be categorized as that. But what works for your skin, and if you're kind of looking for more natural, what the earth gave to us, those were the examples I gave earlier on about the shea butter and the oils, if that works well for you. But I tend to like Aveeno's and Cetaphil, CeraVe, works really well for me and for my boys as well.
Okay. So let's have maybe two more, and then we can have Dr. Yinka have some last words. Two more questions or comments?
Yes. Just from Leah here. It took me a long time to learn that moisture was my #1 skin and hair issue. I grew up in Toronto in the 70s and 80s, and it took forever just to learn this basic skin and hair care principle.
Yeah, so true. I say to people that I have naturally dry skin and they can't believe my skin would be one of those that could literally flake off. And just learning about moisturization has really, really made me more comfortable in my skin, which is why I'm writing in my advanced directive before I go into long-term care, moisturize my skin. Yeah.
Wow. Yes. Okay, one more.
Yes. I have a question here from another audience member. What should we look for when choosing a dermatologist to make sure that they are knowledgeable about Black skin?
So what I found recently is that dermatologists are so keen. Every dermatologist I meet, they're so keen to learn about Black skin, to be representative. Now, this is a difficult one because you're standing in front of me and this is my passion. So obviously you're going to say yes, so I really want to know. But I find that there's lots more knowledge coming up. There's lots more interest and more people are kind of taking that on board. So I'm hoping that when you do see a dermatologist that they're aware and kind of conscious of what's going on. But I still run into some issues. I still have some conversations and I'm like, no, that's not the way it works for Black skin. It's a scary question to answer because we haven't even got enough dermatologists. In Nova Scotia, my patients are waiting 18 months or more to see a dermatologist. So I'm like, whoever you see, just grab it and hopefully they will, do good by you, fingers crossed. So it's a very difficult question to answer. In Nova Scotia, we have no Black dermatologists, and I don't know how many there are in the whole of Canada. So we just, once again, is advocacy by you to say, please be aware that my skin might react a bit different to what you're offering me, or you need to offer me different treatment. So just hopeful for the best, essentially.
Yes, thank you. I don't want to curtail or cut someone off who has an urgent question or even a comment. So Sylvia, can you help me? If I don't want to lose the opportunity to hear from someone. I said that was the last one, but maybe we have one more.
Do have one more comment from Rejane Anderson.
Yes.
Detoxing to cleanse our bodies of harmful elements is an important practice. And many, like Dr. Yakshi Awaken, the late Dr. Serbi, and other natural herbalists have emphasized the healing power of returning to nature's remedies. These approaches highlight the importance of using traditional ancestral knowledge to cleanse and restore our bodies, rather than relying on colonized medical systems that often worsen our health. Our ancestors had a deep understanding of the plants and natural methods that supported our well-being, and it's time to reconnect with these practices. By embracing what they knew, we can heal and reclaim our vitality in a way that truly honors our bodies and our heritage.
Thank you. Thank you. That's very important, and I think we are inspired by that. Dr. Yinka, as we close, I wonder if you can talk to us about what your recommendations were, yes, but also as a family physician and as someone with a particular passion in health, can you talk to us first about your experience in helping to treat clients or patients in Nova Scotia? What is your experience with that? And second of all, could you recap those recommendations that you made earlier so that we can have takeaways?
So my experience is once people kind of knew that I was interested in this, I often get, calls, text, emails about, oh, what's your opinion about this? And when I can, I'm able to say, okay, come in the office, let's have a look. This is the treatment I would offer. And it's not rare. Actually, it's more common than the first option that they have seen a dermatologist. Many Black people have seen dermatologists, but they're worried. The trust is not there. So they say, I have seen a dermatologist. This is what they've offered me. Is it good treatment? Should I go ahead with this? And many times, in fact, in all of the cases, apart from maybe a couple, it was really good treatment because these people are specialists. This is their work, right? It's really good treatment. So it's just to say, oh, that's good treatment. That's good to go. And it's almost like, oh, because you said it, now it's good treatment. No, the specialist said it. That's why it was good treatment. So that element of trust and how we can gain the trust of that community, we need to work really hard at it. We need to work really hard at it. And the last thing I said, which is kind of something that I've been thinking about, talking about, and mentioned it to Sharon, is how to get more family physicians, i.e. me, to get more training so we can offer the opportunities to the people that need us, because the wait time's so long, we have to find a way to meet the needs in primary care. Yes, my wait time's long, but it's not 18 months, right? So it's quicker care for the patient. And if they can see a face that they would say, yes, okay, I'll do what you say, that works as well. Oh, what is my message to everyone in the room? Very easy. You now have your certificate for high advanced level advocacy. So go into the world and change it and spread the gospel, becoming aware that these are the issues, and that if we need to be on the lookout for these conditions, we need to be treating them, we need to be aware that there are a few cultural differences, and that we need to work on the trust, right? So we're all advocates at this point.
Okay, well, Dr. Yinka, I can't thank you enough, and I know everyone feels so much more informed and in fact empowered by this webinar. I want to give my brothers an opportunity to have a last word. We are a family at Hawk. We have obviously we have men and women, young people, older people, and so on. We want to, but I want to give the guys a chance to sort of sign off, because you have a great big audience here. So what would you like to add? I'll go to Brother Mario first.
It was being great being here, and let's talk about, Black skin. Dr. Yinka, I'm gonna let you know I got about at least 4 texts on my phone, and there's a question that they wanted me to ask. So is it possible, can I ask you this question? You talked about sunscreen. So everyone is saying all sunscreen don't work. So can you hit a home run for us, please? What do we use?
Quick one. SPF 30 and above, broad spectrum. SPF 30 and above, broad spectrum. And it's on the label. They have to write it by law because it's almost a drug, because it prevents diseases, right? So check the label. And there are a few brands that now make sunscreen or are aware to look out for Black skin. So don't be afraid, try them, see if they've got little sample products, try them. A few Black-owned businesses, hopefully they make skincare for themselves, so they're aware of how it interacts with the skin. So SPF 30 and above, UVB, UVA, broad spectrum, and I use it every day. And if that's the only thing you use, that's good. Do not rely on just the one on your makeup. Use a product like a skincare product that's sunscreen.
Thank you. And to you, Brother Liston.
A very informative session, because even for me, the myth of, sunscreen, do I really need to wear sunscreen, really drove home to me, because it's something that I've never really done before. And, Dr. Yinka, when you showed that picture of, that Black person who has that sunburn, I recall when I was working in Florida and I wasn't wearing any cap because I was working at the Disney theme park there. I believe when I look back at that picture, I can say equivalent in that I had a sunburn, but I didn't make any attempt to fix it. I was like, oh, my skin was just a little bit ashy. I need to just put something on it, right? So thank you very much for educating myself, and now I can implement this in how I care for my kids, and even educate my fellow Black brothers and sisters about how do they care about their skin moving forward.
Oh, that
Well,
touches my soul. And the other thing is, when you say, oh, sunscreen prevents cancer, they're like, yeah, it's none of my business. Sunscreen is the best. Sunscreen is the best anti-aging. It prevents lines and wrinkles. So to all you vain ones that are not worried about skin cancer, okay, it's an anti-aging. So go look after yourself and glow and shine.
be beautiful inside and out. And you
Absolutely.
certainly are, Dr. Yinka and my brothers. Thank you so much for all you've done today. And I want to hand this over to Sylvia and Louise, if you like, just because I'm sure people are going to want to know about how they might be able to access this. There are others who were not here who might have liked to have had the information. So can you help us with that as we leave today?
Yeah, sure, no problem. So for our audience and for everyone here, we just first want to say thank you for attending, for our panelists, and our wonderful, amazing speaker and our moderator. Thank you once again for your wonderful presentation. I can confirm that there will be a recording of this webinar available on YouTube roughly 1 week after the webinar occurs. And we can send that link out to our audiences. And I know someone had expressed interest in Dr. Yinka's PowerPoint. We can also send that out to you. Over to Louise for any more remarks.
Well, I just want to say thank you so very much. And I'm sorry for the glitches that we had, but we're all professionals. So we all kind of worked it all through together, right? And really, I hope that this will just be the beginning. There's going to be more about this conversation at our summit on November 19th and 20th. This is not the end of this conversation about Black skin and Black skin issues. And we hope that I want to tell you that those people who joined as participants stayed. They were fascinated beginning to end. So that to me is the biggest proof that this was an exciting event, certainly exciting for me, and very knowledgeable. I feel so much more knowledgeable. And I'm so glad I now know how to get rid of all these wrinkles, which is really the best thing you've taught me in the whole thing. So thanks again. We'll be speaking again soon, I'm sure.
Thank you to everyone. Have a wonderful day.